Good evening, everyone. This is Khurram Nasir. I'm the Chief of Cardiovascular Prevention and Wellness at Houston Methodist DeBakey Heart Vascular Center. And welcome to our monthly cardiovascular live prevention series. As in the past, we had multiple guests and venues discussing hot topics of the month. This time I decided to at least give you an update on our prevention and wellness program. Where do we stand? Where are the future directions? Now, before I get started, I just wanted to let you know that it was almost 2 years ago when the planning for this center started way at ACC with Dr. Zogby, and it was clear from the get-go that our co-joint mission was to develop a premium national and international multidisciplinary cardiovascular service line, and we wanted to base its foundation around the concept of personalized medicine. But not only that, wanted to ensure that it addresses Houston Methodist goals and missions in achieving clinical care as well as education and R&D. And of course, initially, we had to start a hub that could provide specialized, excellent care for all across the stakeholders, locally and nationally. And also, not only that, but we wanted to educate and train across the entire spectrum of healthcare practitioners, be it residents, fellows, in trying to make sure that they could take the baton in identifying, treating patients of those developing heart disease, peripheral arterial disease, or stroke. But more importantly, at the same time, not only establishing the latest evidence, but we wanted to also be the leaders in creating new evidence. Now, of course, we needed a team, and looking at the best draft in the country, we were very lucky to recruit one more faculty, Dr. Karsha Patel. Just wanted to introduce him. He is a preventive cardiologist trained from UT Southwestern, very well published. His leading expertise are in cardiometabolic disease, leading the cardiometabolic program, and just recently was awarded a Career Development Award by Houston Methodist. I wanted to introduce our nurse practitioner, Terhas Ohamba. She's really the heart and soul of the program, has an MSN postmaster certification, and truly took a wholesome approach, a holistic approach in her prior version. That experience that she brings in is well appreciated and really something that our patients always look forward to. And not to forget the R&D and the education arm. We were extremely lucky to bring on truly a draft, Dr. Miguel Kenzos from Johns Hopkins, a cardiologist and a PhD from Spain, very well published, major expertise in risk assessment algorithms, imaging, clinical trials, high-risk ethnic groups, and I'll definitely share with you some of the ongoing programs. Now, moving along, as we started building up our clinical program, of course, we wanted to ensure that we had a comprehensive approach. Of course, going from all the way in assessment of the risk, be anthrometric, a lot of emphasis on home blood pressure monitoring, glucose assessment, insulin resistance, the whole range of markers depending upon the risk that we were looking. But the thing that truly distinguished our program was a more deep phenotyping approach, in rather than making guesses, trying to truly assess the underlying presence of subclinical disease with extensive imaging modalities available at our hand, and also at the same time genetic testing for those at risk. Now, although the basic foundation of our program and a clinical program truly lies on risk assessment, however, leveraging lots of gains and from our collaboration with Ciccarone Center at Johns Hopkins, truly the mecca of preventive cardiology, where my friend, mentor, collaborator really developed this ABCD approach. And ensuring that we are very comprehensive in our management, it all based on the complexity of the cardiovascular risk and the issues that needs to be addressed. All our patients are followed very closely for the first 2 to 3 months, and most of them I'll demonstrate in how we try to optimize their cardiovascular risk and well-being. And following that, the care continues according to their patient risk and need, but more importantly, in true collaborative fashion with their primary care as well as consultative team. So just to give you a flavor of the two broad focus that we have, one is truly around those with established cardiovascular disease and those with high risk for future cardiovascular disease. One thing that I truly want to get the message out, that for patients with established cardiovascular disease, although they are above a certain threshold of risk, it's very important to realize that not all are created equal. Actually, this was realized in 2018 ACC-AHA guidelines, where they emphasized for us to look deeper and really make sure that we are able to eyeball the risk and identify those who are at actually very high risk patients. Now, who are those? These are those who are coming with multiple strokes, MIs. And especially, I want to add also one group that we need to emphasize, those who are presenting with recent acute MI. Or if they had just stable CVD in one region with multiple risk factors such as family history, the history of bypass, diabetes, hypertension, CKD, smoking, and high LDL. Now, you may wonder why this classification and categorization is critical and important. So if you look at, first of all, we need to start it among all the patients that you may see in your clinic, how many of them would even make this criteria? In a large national data set of claims, investigators looked in this publication in 2009 in Journal of American College of Cardiology and really pointed out almost 1 in 2 individuals with established cardiovascular disease would meet this criteria. But I would truly like to emphasize on the group, the 1 in 4, 26% who have multiple major atherosclerotic cardiovascular events. And let me tell you why. So if you look at the risk, and over all populations, about 53 individuals per 1,000 person year will have an ACVD event. However, if you emphasize on individuals with 2 major CVD events as compared to who had none, the risk is almost 4-fold, whereas 2.5-fold with others. So again, very critical in the spirit of precision medicine and trying to make sure that we do not 2 CVD patients are the same, and naturally, unless and until we are able to decipher them, we are not going to manage them separately. So this is one of our most important critical goal. Once the risk is identified, then based on higher the risk, more aggressive the management. Of course, the foundation of cardiovascular disease management, apart from dual antiplatelet therapy, is truly around lipids. Within that, huge emphasis on LDL. Now, it's very clear that all of these patients needs to be on a high intensity or what we call a maximally tolerated statin. Now, you may ask, this sounds simple, but looking at national data sets, cardiovascular practices from the NCDR, and even institutional, only about 1 in 5 individuals are on a high dose statin. In a systematic fashion, there is a need to up-titrate statins and ezetimibe, and if that is done, if the target is LDL less than 70, almost about 85% of individuals would meet those criteria. Now, the reason why I also bring in the issue of very high risk, according to the new guidelines from a European Society of Cardiology, as well as emerging data, it's very clear that even lower is better. and the cutoff of less than 55. And of course, thankfully in 2021, we have multiple options, additional coming up, like bempedoic acid, which is the newest player in the market, and PCSK9 inhibitor that has been much more well established. Almost about 10 to 15% with CVD, and then about 25% of these patients would meet criteria for advanced non-statin lipid-lowering therapies, where in reality the utilization is less than 1%. And in very extreme cases, institutional capacity exists for LDL apheresis. Yes, it's definitely rare. I can recount just one patient who are we considering to pursue with an LDL apheresis. However, the process in our clinic is well established to a point that within 2 months of our initial visit, almost majority of these individuals get to this stated target. Now, it's important to realize, does aggressive lipid lowering matter? Yes, it does. So if you look at from these pre-specified analysis from the 4-year trial, where although the initial study focused more on the first event, but as physicians, cardiologists, and preventive cardiologists, it's truly the wholesome picture that matters. Recurrent events, which we understand that almost about 7 to 10% of individuals after their first MI would have in the first year. As you can see, lowering the LDL as below 55 can double and reduce the risk, prevent almost 2-fold more events, about 52 events per 1,000 patients treated for 3 years. So huge emphasis in our lipids programs on LDL targeting, ensuring that almost everyone with established CVD is able to at least get their LDLs below 70 and less than 55. And not only that, but at the pace that we want to get them. A very important area that's upcoming is beyond LDL. The cardiometabolic management is equally important, and especially for diabetes, which almost we see about 20% or more of those. Historically, as cardiologists, we paid little attention to diabetes management, considering that the menu of options we had never demonstrated a reduction in cardiovascular risk. Thankfully, over the last 10 years, we have been blessed with 2 classes of agent, the SGLT2 inhibitors and the GLP-1 receptor agonists, that have consistently shown significant reduction in adverse cardiovascular events, including heart failure, especially with the SGLT2 inhibitors, reduction in the hospitalization. And in fact, if you look at the ACC and upcoming guidelines, actually the recommendation may be consideration of these cardiometabolic agents potentially even before metformin. However, it's kind of a class 1A recommendation, and almost every diabetic patient should be on it. Unfortunately, nationwide, almost about 9 to 10% of diabetic patients are prescribed these life-saving, cost-saving cardiometabolic services, and I don't blame them. And especially within our cardiology community, the prescription is much lower. The irony is that most of these patients in a health system engage with cardiologists more than endocrinologists. And I can understand it's a little bit more complex, because you have to get a sense of which agent, and it all depends whether you are more inclined to be at risk for heart failure versus atherosclerotic, whether weight loss is an option. We have to look at contraindications which are very specific for the GLP-1 receptor agonist and SGLT2. Of course, cautioning the patients on some of those elements that needs to happen. Titrating their other diabetic medications, closer follow-ups. And as for this, we have instituted a diabetes visit only, specifically to understand the need, and more importantly, implementing the best evidence guidelines that can further reduce the risk for these patients by another 20%. One of our 2021 goals is almost 90% adoption, and not only for our patients, but for our DeBakey cardiovascular group. Now, moving along in the same line, weight management is critical. The reason is it doesn't come alone. We see almost about 30% or 20% morbid obesity. There are many secondary causes apart from lifestyle, behavior, and diet, including sleep apnea, insulin resistance, low testosterone, erectile dysfunction that needs to be assessed. Of course, for beyond simple diet management and exercise prescription, we are blessed with a lifestyle weight loss management program that is directed by Dr. Peter Jones, and we have bi-directional collaborative partnership with their group that most of our patients are being prescribed there. Of course, we are very excited about the upcoming role of the GLP-1 receptor agonist, and working with our bariatric surgery group, eventually some of these patients would be referred there. Now, coming back on the weight loss, and we are truly excited about the recent publication a few weeks ago that demonstrated that 1 weekly weight loss dose of semaglutide resulted almost about 15% reduction in the body weight. On an average, 15 kilograms, that's more than 30 pounds over a period of 52 years. And it also resulted in normalization of HbA1c in and about 80 individuals. And in fact, one of the key elements of our clinical service line is rapid adoption of upcoming evidence. And in fact, yesterday was our first patient that we used our weight loss semaglutide dose. Of course, you don't need to forget about the new statin on the block, which is isosapient ethyl, the purified fish oil, and EPA. And in the landmark reduced trial led by Deepak Bhatt, clearly, as you can see, after 1 year, separation of events and reduction in the isosapient ethyl group, including mortality, about 25% reduction, now making a class 1B recommendation by NLA, also by the European Society, and an upcoming ACC AHA guidelines. We are expecting them to be incorporated. Not to forget that most of the patients are not well controlled on their blood pressure, and an additional 15 to 20% risk reduction can be achieved by targeting an LDL 130. Of course, intensive lifestyle modification, including counseling on salt restriction, alcohol consumption, weight loss, exercise regimen. Pharmacotherapeutics are truly needed to ensure an systolic blood pressure 130. For all of our patients, we engage them in a 2 weeks home blood pressure monitoring with our blood pressure management follow-up clinic run by our nurse practitioner, ensuring that almost 90% or more of our patients are achieving that goal of systolic blood pressure less than 130. Huge benefits, not only from an atherosclerotic standpoint, but future risk of diastolic and systolic heart failure. So as I've given you a small flavor on the complexity of managing patients with established cardiovascular disease, thankfully on our protocol and systematic approach, we have been achieving results of almost 90% of these targets for most of our patients. Now, if you start moving the needle from those with established cardiovascular disease to those without clinical cardiovascular disease, the dilemmas are different. The major dilemma is really who is at risk. For example, as you can look at these two patients, tale from two cities. On the left end, a 60-year-old male non-smoker with treated blood pressure and dyslipidemia all over, pre-diabetic, and an elevated global risk score, whereas a 54-year-old male with non-specific lipids, blood pressure well controlled, minimal risk. In the real world, of course, without further due diligence, of course, we will be aggressively treating that at the one on the left versus the right. However, truly, it's a dilemma, because if you start digging in deep, we're not truly sure who among these two individuals would need more aggressive treatment. And the challenges have been that we, for most of the last 2 decades, have focused on a risk factor and a biomarker approach in assessing risk. And if you take into account the conventional view of the risk factors, there's no cutoff of where you can eliminate risk, but as the number of risk factors go up, you continue to increase the risk. And the only remedy is treating those individuals. But the fallacy here is that we are assuming that all of these individuals have a homogeneous level of risk and all of them need an aggressive treatment for everyone. Something that we are very proud, and I think so a foundational approach of our management of those without clinical ACVD is, rather than making guesses, our basic approach is see disease and treat disease. And in this regard, there is no better tool than the non-contrast gated chest CT looking for coronary artery calcification that's now widely available. It takes about 2 to 3 minutes to get that test done. The out-of-pocket cost is around $100 to $150. The radiation dose equivalent to a bilateral mammogram, and provides tremendous amount of information as shown by the wealth of data over the last 2 decades that shows is that higher the burden of your coronary atherosclerosis as determined by coronary calcium scores, higher the risk. Among all the options available, this may be the only tool that can discriminate above and beyond once you take into account your age, demographic, and risk factor, but more importantly, making a meaningful reclassification of a risk where management decisions can be taken. Not only it identifies those who have early disease and at risk, of course, efforts led by our group starting in 2009 for the first time demonstrated that a significant proportion of individuals within the primary pressure setting actually have no detectable coronary artery calcium, now commonly known as the concept of power of zero. And even 11 years back, we suggested that this could be used as a rationale to truly have flexible goals and focus on lifestyle, and potentially individuals can forego pharmacotherapy and advanced imaging. Over the last 10 years, extensive work from our group clearly demonstrated that risk is heterogeneous across the spectrum, whether you're young or elderly, across whether you have no risk factors or multiple, whether you have normal lipids or significant abnormal. And you can meet criteria for statin by the famous Jupiter study, which showed individuals with elevated CRP should receive statin, or by recent polypill studies, and even the ACC/AHA guidelines in 2013. And what we showed was presence of atherosclerosis is extremely heterogeneous. Irrespective of your risk, 1/3 to 1.5 will have a calcium score of 0, and majority events will happen if you have atherosclerosis. You need atherosclerosis to have atherosclerotic cardiovascular clinical complications. Furthermore, for the first time, we also bring in our clinical practice this concept of de-risking, where significant proportion of individuals are seeking insights whether they're truly at risk, can they forego pharmacotherapies and just focus on flexible lifestyle treatment. And as we have shown that no other marker, including a healthy lifestyle or presence of carotid plaque or family history, can truly de-risk one patient, not only from a patient level but at a societal level. We have found that not treating these individuals is cost effective, and colleagues from Walter Reed in a 12-year follow-up, although not a clinical trial but an observational study, clearly showed us that those harboring the fantasy of treating individuals with a calcium score of 0 with statin over the next 12 years, you would find no benefit. As a result, almost 2 years back, when that new HACC guideline came, it definitely recognized the significant advancement of the role of athro imaging, seeing the disease in the last 5 years. But more importantly, the observation that a calcium score of 0, even among those who would be deemed at higher risk, actually translates them into a much lower risk for the subsequent 10 years. As a result of these findings, for the first time, rather than using calcium score as a screening test to find those who are not candidates of statin, and this is something we also adopt in our clinic, is individuals who are candidate for statin, they're uncertain of their risk, and would actually make a decision whether statin, and not only statin, by other advanced therapies, if they have the disease or not. And for the first time, the guidelines suggested that even if you're considered at a higher risk and you're uncertain, and in 1 in 2 of these patients who will have a calcium score of 0, it may be feasible to avoid or postpone drug therapies. Now, of course, one of the things that was cautioned was about diabetes and patients with a significant severe hypercholesterolemia or even smokers. But I think the role of calcium testing is pushing the boundaries even in diabetes, because 2 studies that was published after that clearly showed that as we have the myth of diabetes as CVD equivalent is not true. There are gradients. Almost 1/3 have no atherosclerosis, 1 would have mild, and 1 in 3 would have severe. And clearly, even among patients with type 1 or type 2 diabetes, an absence of atherosclerosis renders a low 10-year risk, allowing flexibility, personal choices for patients, and more focusing on lifestyle intervention. At the same time, with a high calcium score in diabetes clearly identifies a group that is almost as higher risk as somebody with a stable CVD. And in our practice, we implement all of the secondary prevention guidelines, ensuring LDL less than 70 and 55, the need for isosapient ethyl, understanding their cardiometabolic risk, and definitely GLP-1 receptor agonist and SGLT2. Weight loss is a huge focus, and all of these patients end up getting their systolic blood pressure less than 130. Another major focus is for a unique and high need group, and some of these facts are coming from the Familial Hypercholesterolemia Foundation, where a condition where individuals are born with genetic defects resulting in 3 to 4-fold higher LDL exposure since birth. A significant individuals of especially in male, develop atherosclerotic disease by age 50 and women by age 60. Unfortunately, 90% of these individuals go undiagnosed in the country, and as a result, we miss tremendous opportunity. As you can see, that individuals with FH may be at even higher risk for an annual cardiovascular event as compared to ACVD. Now, this is a sobering reminder that how we are able to find these individuals, and working with our primary care group as well as IT and big data applications, we are actively seeking out how to outreach these individuals. But of course, tremendous need of focus of genetic testing that will allow for cascade screening and looking at family members, siblings, and children. Of course, there is a very extensive management program around lifestyle interventions, oral medications, PCSK9s, and LDL apheresis, again in rare cases, but we just recently initiated one for a homozygous FH patient. Although the general current guidelines are very extensive LDL, again in the spirit of precision medicine, we believe that further looking for atherosclerotic cardiovascular disease can help us refine. And in significant ongoing work, initially led in collaboration with Raul Santos in Brazil, where we clearly demonstrated that even heterozygous FH is not a homogeneous condition. Actually, the presence of atherosclerotic disease is pretty heterogeneous, with almost 40% having no atherosclerotic cardiovascular disease. Of course, While in non-FH patients, this helps with the decision of statin. It helps us guide more advanced non-statin lipid-lowering therapy. We believe that maximum statin dose should be used, and we tend to titrate them. And then, depending upon the presence of atherosclerosis, cost implications, personal choices, and values, advanced lipid-lowering therapies, the decisions are mostly anchored around how much atherosclerotic disease is present. Not only that, another group that I would like to mention that our clinical service line is focusing are those with vulnerable populations, such as with inflammatory conditions, including inflammatory bowel disease, rheumatoid arthritis, psoriasis, and lupus. And the reason why we are focusing on that ongoing studies, at least in rheumatoid and psoriasis, have clearly shown that 2 to 3-fold higher risk of cardiovascular disease premature in these individuals. And once you develop atherosclerosis, there is almost a 3 to 4-fold higher risk of dying from them. A third group that we are very interested, and we have initiated a program for 2021, at least in trying to ensure that these high-risk individuals are evaluated early on, inspired by a lot of work led by Dr. Garima Sharma, who is the director for Cardio Ops program at Johns Hopkins, was one of our keynote speakers, where we have learned that individuals with preeclampsia, gestational hypertension and diabetes, and those with preterm birth, as well as with HELLP syndrome and intrauterine growth, significant endothelial dysfunction, high risk for long-term hypertension, and at least 2 to 3-fold higher risk of early atherosclerotic disease. So in 2021, we are definitely primed to develop more programs in screening and early preventive cardiology consultation for these higher risk individuals. Now, that said, I couldn't be more pleased and proud to demonstrate that with this significant, structured, evidence-based, and more dedicated program in aggressively understanding the risk and managing this patient. Over the last 12 months, we have grown, our volumes have grown almost about 4 to 5-fold, whereas about 300 patients are seen a month in our clinic. The good part is a lot of them are also virtual, so definitely room for us to provide those services for these high-risk individuals in the community. Now, as I said initially, of course, the major emphasis was building the clinical hub, but at the same time, we have a very robust educational and a training portfolio. As you can see that we have host a live webcast monthly from the DeBakey studio, but at the same time we have a monthly cardiology fellow seminar where we invite luminaries in preventive cardiology. For example, we had Dr. Zahid Ahmed from UT Southwestern this morning. We have instituted a 1-month training for all cardiology fellows, and many internal medicine residents are leveraging the cardiometabolic elective program. Delighted to announce that we have a 1-year preventive cardiology program that is approved. Our first fellow has been selected that will join us in a few months. And of course, we were very pleased to host our first cardiovascular prevention symposium, bringing in more than 20 world-renowned faculty. Of course, we hosted it live, not in person, but on web, with almost 300 plus participants. There was active faculty participation by our own internal cardiologists and luminaries, and of course supported by national organizations, and we are primed to and ready to roll out our 2021 symposium soon. And also from this studio, as you've seen, every month we have been privileged to bring in experts all across the country, and truly the whole idea of these conversations have been highlighting the burning issues and bringing in the uncertainties and the key questions that are there from our community. From an R&D standpoint, we have been at the forefront and very active with more than 110 peer-reviewed publications, strong national collaborations. 4 areas of our focus has been prevention, public health, health policy and economics, and a lot of ongoing work in machine learning, big data, and AI. A great resource for mentees all across the spectrum of training, where dedicated postdocs, cardiology fellows, residents, not only locally but also from various other national institutes. Now, of course, a few areas of research focus that is beyond 2020 is truly around precision health. And again, to put it together, trying to untangle the heterogeneity among individuals where 2 diabetics cannot be the same, and what are the things that impact not only their health, their response to therapies, their outcomes, and other measures. In this space, of course, as you have seen that we have focused a lot on the non-contrast CT, which I think so plays a major role in population health management in identifying those who need the therapy. But the fundamental concept of coronary atherosclerosis, of MI, has not yet been well studied, and I think so in 2020 and beyond we are well primed using advanced technologies such as multi-detector CT angiogram, not only to look at plaque burden but the types of plaque and the progression and the changes and the impact in trying to untangle all these mysteries. And I see huge coronary atherosclerotic disease knowledge gap. Most of the work so far has been among those individuals who have either with established cardiovascular disease or presenting in chest pain. But in a primordial and a primary prevention setting, we have little clue on the true burden and what type of plaques are present. There is a lot of hype on the non-calcified plaque and their implications. Are we talking about just the plaque or the exclusively non-calcified plaque individuals? What are the biologics and social and environmental determinants of these disease? What about vulnerability? Who develops these disease in spite of no risk factor versus resilience? And in this regard, I was truly honored in 2015 to lead development of a study called Miami Heart Study at Baptist Health, South Florida, where we initially planned to recruit 4,000 but ended up recruiting 2,500 individuals who underwent coronary CT angiograms, one of the most extensive biobank questionnaire, and trying to decipher all of these issues. And hopefully this year, by the time I do some updates next year, we will give you more results in this regard. Now, of course, when we're talking about vulnerability, one group that comes to our mind is those with IBD. While well established in rheumatoid arthritis, psoriasis, little information is on the insights on young IBD patients. Now, in partnership with our GI department, and especially the Center for Inflammatory Bowel Disease led by Dr. Pinsi Ibrahim, and also my dear friend and expert at NIH, Nihal Mehta, who's really led us the understanding of the connection between inflammation and atherosclerotic disease. At least from our first insight, we've suggesting that in young patients, 18 to 44-year-old, presence of inflammatory bowel disease portends a 3 to 4-fold increased risk. Now, what are the biologic process? Is that due to increased atherosclerotic disease, vulnerable disease? Is it vascular inflammation, the role of microbiomes? Biologics should be undertaken? Clearly, our Center for Cardiovascular Prevention and Wellness, again, is well primed to take these questions and translate them into translational studies, as we are almost ready to recruit close to 24 patients in a pilot setting to try to understand with this deep phenotyping approach, hopefully giving us the earliest insight to plan the next big study. Another area is understanding early heart disease in young South Asians, considering the fact that it's now well documented and clear that they are at a 4 times greater risk of developing stroke, peripheral artery disease, but more importantly, acute MIs. And in fact, in Congress, almost a year, last year, a bill was passed to support the heart disease research and awareness in the South Asian population in the US. And of course, our star fellow, Priyanka Satish, has led some of the work, which is shedding some light on the risk factors and the prevalence. But it's interesting to see that despite not having significantly higher risk factor burden, the knowledge gap is: what about early preclinical cardiovascular disease in young population, plaque characterizations, and biologic process of premature CAD? So again, in the same format of precision medicine as I demonstrated on IBD, Dr. Miguel Canzos is planning some of the similar studies. Now, why these are important? For our colleagues all across Houston Methodist, for high-risk group, for example, those with erectile dysfunction, low T, HIV, and other conditions, similar translational science pipelines can be built in conjunction with our well-established program. Now, although we talk about precision, and as we are talking about that, I think so it's very important to realize that data is the new oil in 2021. And I truly remember a quote which stuck with me by my mentor Harlan Cromwell, that says that Google is learning with every click, and Facebook with every post, and Amazon with every sale, and Tesla with every mile. Unfortunately, within our own industry of healthcare, despite being in the age of data abundance, the translational of that to knowledge and wisdom is really lacking. And as a result, not only within Houston Methodist, also within the Division of Cardiology, we have made concrete mission to pursue these assets under the umbrella of the Center for Cardiovascular Computational and Precision Health, and truly building up the infrastructure, which I highlighted in this paper recently published in DeBakey Cardiovascular Journal. How do we lay the foundation for the cardiovascular population management and building the infrastructure that has the ability to create, harmonize, and truly analyze this data, and of course looking at electronic medical records in order to create digital solutions for population health, such as dashboards and those who are falling through the cracks, and also identifying information from other resources, not to forget on the social determinants and the zip data and significant amount of CV imaging that allows us early discoveries in the biologic process of these vulnerability and resilience, and also creating the platform that can allow AI-based automation, risk prediction, prescriptive analytics. We just inaugurated this center, the team's on board. We have in the process of curating almost data for 5 million individuals. As I said, hopefully in the next 12 months, we'll have significant updates in this regard. And in a major area where I also gave a detailed grand round last week on this whole issue of health equity and social justice, and clearly the 2020 was the year where we shed more light and at least became more aware on the continued racial inequities that happened in the time of crisis. But in cardiovascular disease, unfortunately, these have persisted even during the time of calm. But now we're trying to look at them through more the lens of social determinants. Does your zip code determine your health? Under the umbrella of the Center for Health and Nature, significant efforts are looking at pollution measures, greenness, access to parks, and of course, not to forget the significant financial toxicity that happens as indirect consequences of medical care for these patients. Now, to pursue these actively, we have just inaugurated our Division for Health Equity and Disparities Research at the Center for Outcomes Research. And the whole idea is that we are going to engage the health systems and community stakeholders for advancing the health equity. Hopefully, this can become a hub to foster collaboration among the underrepresented populations within the academia, industry, and policymakers. And truly, we want to eliminate and use this center to generate evidence tool and guide to eliminate racial disparities focus on social determinants of health and financial toxicity. Of course, eventually, in partnership with our system, support the programs that can eliminate the unmet social needs. And hopefully, in doing so, we can lead local and national efforts in achieving equity and justice in healthcare. So, unless and until we achieve health equity or move the needle from disparities to health equity, neither our co-joint goal of population health and prevention will be fully achieved. So, in the end, as you can see that over the last 12 months, we are extremely delighted and proud to build up a robust clinical service that's serving almost 300 patients across the range of well-established individuals with cardiovascular disease. It has also become an amazing hub, and I can tell you, I learn more in interacting with these young physicians, and just training them, I can say that the future is bright. And at the same time, tremendous R&D opportunities by focusing and utilizing these existing resources. So thank you so much again, and I will now open the forum for few questions. I had already received few, and I can start with them, but if you have any questions, you can send it to us by text, and text DeBakey to 37607, and you can text in your message, or you can go to paulev.com, enter DeBakey, and respond to the activity. And let's see, how many questions have we received so far? Let me bring it up. Okay. The first question is, I am a cardiologist at a satellite Houston Methodist clinic. We have patients with MI who need more extensive prevention support. How can we approach, and how our group can support these efforts? So, the clinical service line that was established is truly in not only a Houston Methodist resource, but we aspire to be for the entire family across the system. 2020 allowed us to develop more digital access, telehealth services. It's very easy. If once these patients are referred to us, and within 2 to 3 telehealth visits, not only we assess their risk, but all across the entire spectrum, especially if you're sending in a patient with an established MI. And within 2 months, we tend to get their LDLs below 70 or 55, depending upon if they are an acute MI. Assess the need for isosapient ethyl. Work if they're diabetics, ensure that they are either on one of the 2 cardiometabolic agents. We ensure that they get the guideline-directed medical therapy and achieve their home blood pressure less than 130. And of course, tying them with a well-established lifestyle and intervention program. And all of these happening within the comfort of the patient's home. They don't even need to come to us. Most of the services have been provided at your end, so it becomes very easy for us to manage. So absolutely, that should not be an issue. Okay. The next question is, what's the best way to refer my patient to the cardiovascular preventive cardiology service clinic? Well, this was a question that was sent to me in advance, so I have a slide. The best way to refer to preventive cardiology is you can send us a message on preventivecardiology@houstonmethodist.org, or call on this number, or through the cardiology referral service line. We have a clinic that goes through Monday to Friday, and we accommodate patients as soon as possible. If we receive a refer today, so far we have been able to respond, seeing those patients depending upon within 2 days. Some of our efforts now, we are also working with our population health management team led by Dr. Julia Andreani in trying to create rapid access for similar high-risk patient for ACO and MSSP. In a similar effort with the hospice team, with Dr. Ryan, we are in discussion in how these high-risk patients who are being discharged can be seen, evaluated, and at least their cardiovascular risk managed within the first 2 months, overcoming the therapeutic inertia. As you would know that post-MI, less than 30% of patients get to their LDLs less than 70 in the next 4 months. So we are trying to overcome those inertia, so some of those efforts can happen there too. Let's see what else are we getting. What are the main conditions we should consider referring patients to the primary care services? This was also a question that was sent us. So in essence, if you look at anyone with a personal or family history of cardiovascular disease, so somebody with an established cardiovascular disease, especially with multiple vascular belts, multiple events, or an early cardiovascular disease, needs more dedicated risk assessment and very aggressive management. And the issues with the management is that not only there are multiple options and multiple pathways, but the process of prior authorizations and many other clinical processes needs to happen before we can achieve those goals. Thankfully, we have systemized that in our clinics, and most of these individuals are able to get to those goals much earlier than in real world. Of course, apart from those individuals with inflammatory disorders, severe lipid disorders, we have in the last year or so seen and served close to 150 individuals and family members with familial hypercholesterolemia. We're definitely making inroads with our groups who manage and deal with inflammatory conditions. As I pointed out, those with a history of complicated pregnancy is one group that we are learning that it is a high-risk group. With our men's health clinic, we are planning to have a joint program around erectile dysfunction. Anybody with diabetes, I think, should definitely get a calcium score, and not only for the decision of statin. The question would be whether they need to be managed as somebody with an established cardiovascular disease. Resistant hypertension is a big space for us, and of course, anyone having challenges with the common statin utilization. So I think so we are almost at the end of the hour. I'll take 2 more questions, and one is my patient had a recent MI. We maximized the statin and ezetimibe. The patient is symptom free. LDL is 85. Do we need to pursue more? Now this is an interesting issue, and I would say something very common that you're going to see in majority of individuals where you maximize statins and have them on board with ezetimibe. A lot of them are going to have their LDLs in the range of 90s, and this is kind of almost similar to what you would see in the original Fourier trial. However, an interesting piece for where I have conversation with my patient and more on a shared decision basis, because again, our job is to inform the patients, allowing them to make personal choices in the setting of uncertainty. So if you look at the data, even in individuals with baseline LDL of 80 to a 90, the 10-year risk and the benefit is, not the 10-year risk, I meant in the next 3 years, lowering their LDLs all the way down to 30 with additional lipid-lowering therapy such as PCSK9 offers you almost 1.5% of primary event relative absolute risk reduction, and almost the similar 20%. Of course, there are issues that happen with out-of-pocket cost, utilization of injectables. As a result, a lot of these conversations needs to happen with the patient, but majority of those, if your goal is to truly optimize the risk, then definitely consideration of either PCSK9 inhibitors and bempedoic acid, although there is no event data yet, but would definitely reduce their LDL to goal. One question which is that how do you use calcium testing, and would you use it for management in individuals with severe hypercholesterolemia? Now, this is definitely, I would say, pushing the boundaries. And if you look at the evidence and the guidelines, generally the recommendation is anybody with an LDL greater than 190, and of course 7% of those may have familial hypercholesterolemia, especially in the presence of significant family history, other signs and symptoms that may relate, to familial hypercholesterolemia, such as xanthoma, but definitely an area of uncertainty. And I can tell you that it's interesting that this was an issue that we brought up, power of 0 in severely elevated LDL. Should we treat everyone? And last year I did post a question that what about severe hypercholesterolemia? Are all of them the same? Should they all receive the aggressive treatment? This is definitely a big unknown. And of course, in response, I wasn't all alone. Many other folks raised similar issues, and I really loved Michelle's feedback that this is definitely a guideline-free zone. But thankfully, and after that, from the multi-ethnic study of atherosclerosis, which showed that looked at the calcium scores among individuals who had severe hypercholesterolemia. Of course, mind you that the diagnosis of FH was not established. And what they found that in circumstances when these individuals have a calcium score of 0, the risk is not 0. And by the way, we should never assume the risk of a calcium score is ever going to be 0, because there's no such thing. But at least in 10-year follow-up extending up to 13, the 10-year event rate was around 3.5%. That means 3% in the next 10 to 13 years will have an event. And by the way, our guidelines threshold for consideration of statin start at a level of 5%. And with my colleagues Marcio and Dr. Moaz Al-Mallah at Methodist, we kind of brought that whole issue again and saying that non-pharmacological interventions may be recommended to all, and of course we need to, but in the condition of being non-FH, potentially statins could be offered in a shared decision making. Again, as I said, our job is to inform, allowing the patient to make the best decision based on their own preferences and values. And I truly see that we can extend those prognostic findings even in severe hypercholesterolemia. Now, when we're talking about familial hypercholesterolemia, the calcium testing is really not about statin decision. As you can see in this study, about 230 patients, nearly half of them a calcium score of 0, even in mid-age, almost 5 years, no events. We did a meta-analysis and found that almost similar findings are seen elsewhere. And what we feel that there is definitely a role of calcium score of 0 here, but not for statin decision. If you have a FH patient, I think all of them needs to be on a moderate to a high dose irrespective. However, the need for further evaluation with either calcium and I think a CTA may not be unreasonable to ensure that there is no missed non-calcified plaque. And in absence of those atherosclerotic cardiovascular disease, and I can give you an example of a middle-aged patient with LDLs greater than 400 with normal CTA, statin intolerant, cannot tolerate Zetia, never went on a PCSK9, and now is unsure because have no plaque, even age 55 and above, whereas a young 34-year-old with LDLs well established in their 80s and on a high-dose statin and have significant amount of atherosclerosis, and we aggressively pursued lipid lowering. So again, what I truly want to highlight again that guidelines are fantastic, but in one size fit all approach doesn't work, and that is really the foundation of our clinical service line, whereas the goal is really trying to understand the patient, their risk, their needs, their preferences, and then creating a tailored management. And I hope this discussion was helpful, and hopefully if there are any questions and any of your patients that would need help or any programs that you think that the Center for Cardiovascular Prevention Wellness, not only from the clinical service line, but also from educational portfolio and especially developing R&D joint programs, I'm more than happy to speak more. But thank you so much for joining us today this evening. See you next month.